I'll call second speaker, Dr. Lekha T. She is senior retina specialist in Girdhar Hospital and taking care of ROP in Girdhar Hospital. Ma'am, to you for treatment of ROP, lasers versus anti VEGF.
Thank you, Dr. Anubhav. So, good morning to all of you. Before choosing what is the correct modality of treatment, let's have a little more clarity as to when and whom should we treat. And this question was answered by the cryo ROP study, which defined what is known as a threshold disease. That means any ROP in zone 1 or zone 2 with stage 3 plus disease and extending at least 5 contiguous clock hours or 8 cumulative clock hours. So at that time, only when the ROP reached the threshold ROP, it was treated, because if you don't treat, 50% of them will progress to retinal detachment. And cryo being the only option at that time, it was used to treat the entire avascular retina, extending from the ridge to the oris areata. But when we look into the results, we can see that a significant percentage of eyes had unfavorable functional outcome. So this led to the realization that treatment has to be done even earlier than threshold or in the pre-threshold stage, and this led to the early treatment of ROP, that is ETROP study. So this study guideline says that very posterior, that is in a zone 1, any stage with plus is an indication. Also stage 3 without plus is also an indication for treatment. So we are no longer concerned about the extended clock hours. Or if the disease has come to zone 2, stage 2 or 3 with plus is an indication. And this is now we call it as a type 1 ROP. And by that time LIO was available, so the treatment was done with laser. And we can see that it helped to reduce both structural and functional unfavorable outcome, and it became established as a standard of care in ROP. So laser can be done either with the red or the green laser, and always written informed consent should be taken before any of these procedures. It should be done under proper monitoring in an ICU under local anesthesia. Start with the area which has the maximum severity and fill the entire avascular retina and try to complete the treatment in one session. Post-treatment, we give antibiotic steroids for 1 week. Follow-up is very important. Now, this is a baby with type 1 ROP, and this is a post laser. You can see the significant laser posterior to the ridge, and this is a modified concept which has come, that is known as the posterior to ridge or barrage laser, which helps to create a chorioretinal adhesion in the healthy retina and helps to prevent the progression of traction. And this is preferred in cases of advanced stage 3 or 4A where it causes faster regression. So the follow-up has to be done after laser every 2 weeks, or if you find any that the plus is persisting or there are skip areas, don't hesitate to give additional laser. And very rare cases, if there is fibrovascular proliferation and if it is progressing, then we may have to proceed with the surgical intervention. But in spite of laser, which definitely gave much more advantages compared to cryo, a significant percentage, especially in the posterior ROP, was found to have poor results, and another issue is the large peripheral visual field effect. And moreover, it is a very tedious procedure taking long time. So it is said that treating ROP needs H4, that is heads, hands, hours and a heart. So I'll just show you this picture. This is a baby who had undergone laser. You can see significant amount of peripheral retina is ablated. But if you compare this, here also the ROP lesion was in the same location. But as you can see, after the intervention, the plus has gone, the ridge has disappeared, and there is good progression of the physiological vascularization till farther into the periphery. And this is what we can now achieve with anti VEGF therapy, because it helps to suppress the circulating VEGF levels, which is there in the phase 2 of ROP. So now anti VEGF has become the preferred choice in all posterior, that is zone 1 or zone 2 posterior type 1 ROP in AROP, or when the laser is not feasible either due to media opacity, poor dilatation or a sick baby, and it's definitely causing faster regression than laser. So this was followed by various randomized control trials to know the safety and efficacy. We have the BEAT ROP study with bevacizumab, who found there was a significant benefit in zone 1 compared to laser, but in zone 2 both are almost the same. Similarly, the Rainbow study with ranibizumab and the Firefly study with aflibercept definitely showed that anti-VEGF has a superiority with laser, and ranibizumab is also approved by the DCGI India. So the injections are always done in the NICU, and again I'm stressing on on the proper consent taken from the parents. It has to be done following all the aseptic precautions as in a case of adult injections, proper prepping and cleaning and preppings, draping. And we do the injection within 1 millimeter of the limbus using either a 1 cc syringe or a tuberculin syringe, and post-injection antibiotics has to be given for a week, and baby should be followed up within 24 to 48 hours. So one thing to keep in mind is the direction when you pass the needle. So unlike in adult cases where you direct it towards the center, here it has to be straight, parallel to the visual axis, because the lens in these babies is much thicker, and this is important to avoid any lens touch. So keep in mind the complications, because this is an invasive procedure, and the complications can also be drug related, mainly the transient effect of the injection. So by 1 month or so, the effect goes off and we have to deal with the recurrence. And we also don't know the long-term results with angiogenesis, with the development of CNS and neural retina. So all these information should be there in your informed consent and explained to the parents. So this is a case of aggressive ROP, or we can even call it as a half-zone ROP, who has responded very well to anti-VEGF injection. You can see the response is so good, and it's not like a destructive change that you see with the laser. This is another baby. We can see there is zone 1, stage 3 with plus. So as is the preferred method, anti-VEGF injection is given. And you can see there is a good improvement. The plus disease, the ridge, everything has gone. But there is a lot of peripheral retina still be vascularized. So this is what we call as regression post-injection. And as we continue the follow, by 5 weeks, you can see a ridge has started appearing. So this is recurrence of ROP. And for that avascular retina, we have to do laser. So now we have regression of the recurrent ROP. So this regression, recurrence are all those terms which has come more following anti-VEGF therapy. So this can occur any time between 37 to 60 weeks, and it also depends on the choice and the dose of the drug. It need not, this recurrent ROP need not go through the stages of the conventional ROP, and it always should be documented as a recurrent or a reactivated ROP. This is another scenario, again post anti-VEGF injection. You can see that the peripheral retina is remaining avascular. Even at 7 weeks or 46 weeks, the baby has reached. So you cannot continue to keep screening them, and the baby is also growing, so we have to treat them. So this situation is known as a persistent avascular retina, and if you leave it, they can develop holes and lattice. So this is another indication for laser following injection. So as we can see, anti-VEGF has its ups and downs. The main problem is a high recurrence rate and the need for a long follow-up, whereas with laser, all this is overcome, but it is a more destructive treatment. So to combine the advantages of both, we resort to the combination therapy, where the initial blocking effect of VEGF and the continued suppression by laser is being utilized. This hopefully helps to reduce the dose of the anti-VEGF and less recurrence, so that less follow-up also, and you get a much better visual field. And it has been found to be superior compared to the laser. So standard of care for ROP even now is laser, but combination therapy is an option when you are dealing with zone 1 or zone 2 posterior and in AROP. But we don't have the final answer for many of issues like late recurrence, which is the ideal drug dose, and extended follow-up has to continue for any baby following anti-VEGF. And finally, the choice depends on a case-by-case basis. And this is my teacher, Dr. Subhadra Jalali, and from sight to blindness, you can make the difference. Thank you.
Thank you, ma'am.